Okay, so I'm going to run through a few housekeeping, but also I just want to say good afternoon and welcome everyone to SCOGO's Summit for 2023. So my name is Aika Washington, and I'm a health and social development and equity specialist. I'm grounded in public health and community health work with Diversity Talk. I'm also a PhD student in health policy and equity at York, and I've been a longtime volunteer as well with SCOGO. So today I'll be moderating the session on clinical track 2B, which is on organ damage and sickle cell disease prevention, management, and cure. In today's session, we'll be hearing from Dr. Robert Klassen, and who will be introduced shortly. But I wanted to cover some housekeeping rules which will be followed by his presentation and then a Q&A session. So we ask that you kindly respect the learning that's being done in this space by abiding to these rules. So your microphones have all been disabled during the duration of this webinar. And if you'd like to ask a question, please feel free to do so in the chat or the Q&A. The Q&A function is preferred, but also if you can also raise your hands if you feel like you need to speak instead of writing. Also, there's a translation captioning that is provided at the bottom. And also, if you please use respectful language in the chat. So we ask that there's no profanity or inappropriate images or things posted, and you will be removed if that is the case. But I expect that we are all here to learn. So and also, please do not post anything that is unrelated in terms of today's topic. And also in terms of medical information, if we can just keep it at a minimum. Unfortunately, Dr. Klassen cannot be everyone's doctor, but he can provide the information that we do need, and that we keep the discussion and topic on the comments as well on topic as much as possible. And then we will also be addressing your comments and questions at the very end of the session. So please feel free to do that throughout the session. However, we'll be attending and answering those questions towards the end. Without further ado, I'd like to introduce our speaker, Dr. Robert Klassen, who is a pediatric hematologist and oncologist, and the program leader for the hematology program at the Children's Hospital of Eastern Ontario, as well as a full professor at the University of Ottawa. Dr. Klassen has always been a strong advocate for patients with hemoglobinopathies. He is the founding member of the Canadian Hemoglobinopathies Association, and he has successfully co-chaired 3 conferences focusing on hemoglobinopathies, including the first National Canadian Sickle Cell Conference. In 2005, he actively lobbied the Ontario government to include hemoglobinopathies in the expansion of the newborn screening program. He is also the lead owner and inventor of the quality of life measurement tool for thalassemia called the TranQual, which has been used in numerous multi-center clinical trials for patients with thalassemia. So over to you, Dr. Klassen.
Well, thank you for that. And I should give a little prep on how to say hemoglobinopathies, because I know people have a lot of trouble saying that, but it's basically sickle cell disease and thalassemia together. Yeah. That's fantastic. So at this point, I'm going to share my screen.
And while Dr. Klassen is sharing his screen, everyone, if you have questions as Dr. Klassen is going through his presentation, please put them in the Q&A box. You can also use the chat box. I believe Ms. Aika have mentioned that, but I just want to reiterate that is very important. And there will be a poll that will pop up about 5 minutes before the end of the session. Please put your feedback and help us understand what we've done well and what we need to also do better. Thank you. Thank you. And go on, Dr. Klassen. Thank you.
Okay, great. Yeah, I just want to say, I don't know how many of you were also at Dr. Kuo's session, which was immediately before lunch. So there's some overlap, and there's a lot of things that he covered that I'm not going to cover in this talk. So I hope we're going to get some of those saved. So if you didn't see his talk, it's a very good sort of complement to what I'm going to go over today, because I thought it was very good. So I'm going to talk about organ damage and sickle cell disease prevention, management, and cure. And so I'm going to talk just quickly about organs affected. And I just want to know, especially if your patients with sickle cell disease, it's going to seem kind of depressing the way we start. I apologize for that, but we're just going to go through all the potential issues, and then we're going to go through treatment options, and then talk about potential cure and going through a conclusion. So we hopefully end up on more of a bright note, I'll put it that way. So I think everybody knows with sickle cell disease, but just a reminder, it's a problem with the red blood cells. They're donut shaped. You have they actually look like donuts, but no hole all the way through in the middle. It's just narrow in the middle. And then in sickle cell disease, they get shaped like these sickled cells, which is where the name came from. So this was a nice description of I think we tend to think of the problems in sickle cell disease related to this half of it, which is called vaso-occlusion. And so you have these nice donut-shaped red cells, which kind of, they're very flexible, and they can kind of squeeze through the small blood vessels called the capillaries, no problem. They're very good at that. The sickled cells, on the other hand, are kind of rigid, and they tend to block, and they kind of block things up. And then because you block up the small blood vessels, you stop the blood flow, and you don't get enough oxygen to that area, and that area can die. So that's one of the basic problems with sickle cell disease is slowly but surely you're basically cutting off the blood supply to different parts of the body, and that's where the damage happens. So that's the one we typically think of, which called vaso-occlusion. So vaso being blood vessel and occlusion being blockage. So blockage of the blood vessel, which we often think about. But there's also another side of it where the red blood cells tend to be more fragile and break apart. And the part of this is NO is nitrous oxide. So you think of it as laughing gas. So people think of when you go to the dentist, or when young kids go to the dentist, they can get laughing gas. But it's actually kind of an important part of sort of maintaining the blood vessels and the lining. And so anyways, this breakdown can also lead to damage in the lining of the blood vessels, the endothelium, what's called the endothelium, the lining of the blood vessels. So yeah, there's damage to the lining of the blood vessels is one part, and you have this blockage of the blood vessels is the other part. So the blockage of the blood vessels leads to the things we typically think of as sickle cell disease, which is pain, the pain crisis. And I know there's a pain session going on right now. I'm competing with a really good group of pain, so they're giving a nice talk. So those of you may be on the other session learning about the treatment of pain, but that's what the vaso-occlusion causes pain. It can cause this thing called acute chest syndrome, and I'm going to show you some slides on that a bit later. And then bone disease, so osteonecrosis, which is kind of basically cutting off the blood supply to bones, and we'll talk a little bit more about that. And then the other side, this damage to the blood vessels leads to high blood pressure in the lungs. It can lead to lung ulcers, priapism, which is painful erections for men, and stroke. So those are the things we talk about. So there's a nice overview. This is in the New England Journal 2017. They kind of went through the various organ systems. So I'm going to go through this piece by bit to kind of go through it. And I think it's helpful. So if we call cardiothoracic system, so if we look at the heart and the lungs, basically, you can get this acute chest syndrome, which is problems with the lungs. You can get a chronic lung disease, restrictive lung disease. You can get high blood pressure in the lungs, and it can then have effects on the heart. You can have arrhythmias of the heart, and this is the concern. You can potentially have sudden death from basically irregular heart rhythms, and then you could have affecting the function of the heart. So that's the cardiothoracic. The nerves, again, I apologize that this is kind of a depressing list of all the potential problems can happen, but I think it's good to be aware of. I think especially when we're looking at the treatments, we need to be aware of what we're up against. So the nervous system, you can get the problem is you can get strokes. You can get an acute stroke, which is the blocking of blood supply to the brain and causing a stroke. And stroke, for those of you who've probably seen somebody, but you have weakness on one side of the body, on one side of the face. You can have that. So you can have it as the blocking the blood vessel causing a stroke, or you can have a bleeding into the brain. And you say, well, why would you have bleeding? Because what happens is you damage the blood vessels and they become more fragile. And also you tend to use kind of smaller blood vessels to get around any blockages, and those are more fragile as well. So because of the fragility of the blood vessels in the brain, you're prone to, and this is, so the blockage of the blood vessels is more of a problem in children. Bleeding into the brain is more of a problem for adults with sickle cell disease. And you can get a blood clot in the brain. There's a vein in the brain that can have a blood clot, and you can have, again, strokes that you don't manifest with the symptoms of the arms and legs. You don't see it outside, but actually it can affect brain function. Another area, and we think of the eyes as kind of an extension of the brain. So you can get problems with the blood vessels at the back of the eye. So you can get problems with seeing. And this is why I think it's important to understand this, because I often, my patients, we send them for routine assessments every 2 years to see the eye doctor. And I think often people wonder why. What does this got to do anything? Because the damage that happens at the back of the blood vessel, sometimes you can fix those blood vessels, but again, they're fragile blood vessels and they're more prone to bleeding and getting what's called retinopathy. So you can actually potentially go blind from sickle cell disease, and you can affect the blood supply to the eye. And then as far as the nervous system, the pain issue, which is well known, you can get chronic pain problems. And because of this, problems with strokes to the brain, you can get problems with brain function. So you have trouble with, so in the past, before many of the treatments I'm going to talk about, the overall IQ of patients with sickle cell disease was lower because of these small lack of blood supply to the brain, affecting brain function and affecting your ability to think. So those are two areas. The other one is called, this is reticuloendothelium, which is the blood system. And so the blood system, we think of, you can get anemia. So we know that because the hemoglobin is low, you can get anemia. So you have lack of energy. You get splenic sequestration. So the younger children, because the spleen's job is to clean the blood. And what it does is it sees these abnormal cells and it tries to remove them from the blood. But by doing that, you can actually, you make the spleen look quite big, and you can actually almost basically bleed into your spleen. So your blood volume actually goes into your spleen, and you can get very anemic and can get very sick, and it's life-threatening. As you get older, the spleen gets damaged by the sickle cell disease, and it actually stops working. So you get splenic hyposplenism, functional hyposplenosim, which basically means the spleen stops working, and then you're at risk for infection. So that's why we talk about antibiotics and in sickle cell disease, is because you damage your spleen, and your spleen has a very specific role in fighting infection. And this is very interesting, because I don't think people really kind of think about this. Is you can get problems with your bone, and it's called avascular necrosis, and all these fancy sort of Latin Greek terms, but avascular, basically no blood vessel. So there's an impact on the blood supply to the bone, and because of that, it dies. So it's basically saying, fancy way of saying you have part of the blood to the supply to the bones die. And I think people are a bit surprised by that, because they don't really think of bones being alive. We just had Halloween, and people, they have all these pictures of skeletons walking around, or you have this idea of skeletons walking around and of dead people as skeletons, but you need to have a blood supply to the bones. Otherwise, you need it for remodeling, because you damage your bones and you need this remodeling to keep them strong. So if you cut off the blood supply, you end up with bones that can't remodel, and then over time they soften and they're not structurally sound. So it's a very real problem, and we do, unfortunately, even with children, we have patients who have problems with. It particularly affects the big long bones. So the humerus is this big long, the upper arm, and then the femur. So we often see this in the femur and the humerus are the big ones where you can see that. And then lastly, you can get skin ulcers. Urogenital, we think of, you can have impact on the kidney. Again, there's a lot of small blood vessels going through your kidney, which you may not be aware of this, but because the kidney's job is to filter the blood. So it's got all these kind of small vessels filtering the blood. And what happens, you can actually, if you block off part of it can fall off. You can get necrosis, again, death of part of the kidney. We've seen patients who get blood in their urine because of that. They can get protein in their urine, and worst of all, we can talk about renal failure, where your kidneys actually fail. My wife is a kidney doctor, and she says, fortunately, there's not a lot of patients, but there are definitely patients with sickle cell disease who go into renal failure, need things like dialysis. And some of it is that we're a bit of a victim of our success. As we sort of fix some of the other problems, then some of these problems like kidney failure can show up because people are living longer and have more time to develop these problems. With children, we worry about this nocturnal enuresis is basically bedwetting, which teenagers can be very embarrassing because they have problems controlling because you don't concentrate your urine like you normally do, so you can wet the bed. And then this painful erections for men, which can be really devastating, can end up with being impotent, where you can't actually get erections. So that's a horrible, so it's A, it's painful, and B, you can end up being impotent. And then the gastrointestinal system, you can get gallstones, problems with your liver, and then you can actually obstruct the blood flow going to the intestines. So sorry, a very depressing kind of spectrum of all the problems that can happen with sickle cell disease. Just to kind of give you a little bit of a better perspective of what's the more common things, and I'm a pediatrician, so I'm going to default a bit to this study of children who were followed for 10 years. This is a study done way back in 1995. So this is the natural history without the current treatments we have now. So this was almost 700 infants were followed for 10 years. And one of the biggest problems is you can see they get infections. So 20% of the patients, so this is the different kinds of sickle cell disease. The most common one is SS, and 20%, so 1 in 5 children had blood infections. So this isn't just minor infections. It's not like an infected fingers. This is blood infections, or you get very sick and can die. And actually in this, 11 patients died of blood infections, all with the SS kind. And this study did a nice job of following these patients. And just so these graphs are very interesting. So you can see the age, how when they're followed for their 10 years. And it starts at 100%. So that means that nobody's had a problem. And then each time you see a little tick down here, that means that one patient, so you see the little ticks here, one patient has had a problem. So this is for a pain crisis. You can see over time, basically half the patients had, you can see by age 5, half of them had pain crises. And it varies depending on which kind of sickle cell disease, but you can see what happens. Related to this, you can get pain in the hands and the feet. So it's a hand-foot syndrome. You can see that about a quarter of the patients had that. And getting back to my thing about the bacteria, you can see there over time, again, each time this means somebody got an infection, blood infection, and you can see by age 5, you had more than 20% of the patients that had a blood infection. Almost 30% of the patients had a blood infection. And here's, again, so this gives you an idea how quick, so this happens very young, very early on in life. And this is that spleen. This is needing a blood transfusion here, and this is the spleen event needing here. So, and here, just talking again about these problems with the hand-foot syndrome, the pain syndrome, and the pain is quite prevalent. So there was another study which looked at 37 children with pain diaries, and 7% of their days they were in pain, with a wide range of some having no pain and others having pain every day. So you can see that is a real problem. Now, I wanted to talk a little bit about this chest syndrome because it's a very common problem, and we're seeing even in children, we see this. It's when you got this new change on your chest X-ray, they call it infiltrate and I'll show it to you in the next slide, and one of having a fever and wheezing or chest pain. So if you have any of these symptoms and you do a chest X-ray and you find a change, that's a chest crisis. And they did a study looking at chest crisis that many are due to bacteria. They can have problems with not inadequate blood supply to the lungs, fat or bone marrow emboli. So that basically means you have pieces of fat flying off into the lungs or bone marrow flying into the lungs, and virus infections. And of these patients, 13%, so 1 in 8 or so, was put on a ventilator, and 3% of them died. So it's a very serious problem. Again, I want to point out this is an older study, so hopefully it's not, the outcomes are a little bit better now, but I just want to be aware of it. So this is what a chest crisis looks like. So this thing, so these, you can see the ribs going around. That's what the ribs are, the rib cage. You can see the shoulders on either side. And this thing in the middle here is the heart. So that's the heart. So normally the lungs look like this, where they're fairly more dark and they're fairly clear. And you can see you get a nice, this is called the diaphragm, which is the base of the lungs. And this is the edge of the heart is pretty clear. Whereas on this side, you really don't have the diaphragm, you lose some of the heart. So this is where that chest crisis is. You can see how it's kind of white. That's what a chest crisis looks like. And then stroke, we talked about that. So the median age of stroke is incredibly young in sickle cell disease. It is by far the most common cause of stroke in children. And it happens on average at a very young age, up to 13 years. And then we know that patients with sickle cell disease, over 10% of them will have a stroke, an overt stroke, with no treatment during their lifetime. That means where you have weakness of the arm and the face. And there's one death related to a stroke in that. And I was telling you a little bit about the different kinds of strokes. So in children, we tend to see what's called this ischemic stroke. So brains are normally pretty symmetrical. They're usually the same one side versus the other. So you can see on this one that there's this kind of line along here, and this part's a bit darker, and that is a stroke. It means there's not enough blood going into that area, and that's what causes the stroke. So that's what that ischemic stroke means, is not enough blood supply. And then the hemorrhagic means a bleeding stroke. And remember, I was telling you with adults, they tend to get this kind of stroke where they bleed into the brain. So I'm going to thank Dr. Tinmouth. There's a few slides in here that I borrowed from his because he did such a great job. But he talks about the increasing the hierarchy of treatments for sickle cell disease. So those are all the problems. What do we do about it? So we've kind of looked at what our problems are and how do we make that better. So the most common treatment we use, and I've talked about this in previous episodes, is hydroxyurea. Very cheap, been around for a long time. You can do simple blood transfusions. Then more advanced is you go into red blood cell exchange, and I'll talk a little bit more about that. And the curative therapy, which is stem cell transplant. I'm not going to get into gene therapy, which Dr. Kuo talked about, but that's another option that's maybe coming down the pipe soon. So hydroxyurea, I just want to remind people, this drug was made 150 years ago, a long time ago. This is a very old drug and very simple little drug. It's just tiny. And so the good thing about it, because it's so old, it's very cheap. And the good thing is it's very simple to make. So the way it works is by stimulating the production of this fetal hemoglobin. And that's the hemoglobin you have when you're inside your mom. And it doesn't sickle, so it actually inhibits sickling. So that's why more of that fetal hemoglobin is good. And this slide is great because I think it shows it very clearly. And in an ideal world, actually in the clinic, we would take everybody's blood, put them on a slide and show it to them, because I think it really hits home. So you can see here, without hydroxyurea, a patient with sickle cell disease, remember I was showing at the beginning, there's the donuts. So this is, I'm showing you in real life that, you know, I didn't make that up. This is what they do look like donuts. That's what normal red blood cells are. And then you can see these sickled, abnormal sickled cells. You can see them all over the place here. Then we start at hydroxyurea, and you can see the number of cells. There's still a few sickle cells, but it definitely comes down. And then the last one is at the sort of called maximum tolerated dose, or an optimal dose. And you can see there's no sickle cells seen on the slide. So dramatic improvement with hydroxyurea. So this is a real win for the sickle cell community. This is a cheap drug, readily available, and it works incredibly well and with very minimal side effects. And this is a study done in children. It's called Baby Hugs. And I like to do, because I'm a pediatrician, I like referring to it. One of the things I want to point out is they were, because it was a newer, this was done and published in 2011, and because using hydroxyurea in babies was a new thing, they actually were on the conservative side. They didn't go to the maximum tolerated dose. So they're kind of in the middle, like I was showing you before. And this is a flip side of the member slide. The other slide is that you start at the top and work your way down. This one you start at the bottom and work up. So this time, every time there's a little tick, it means that somebody had a complication. So, and the blue is the placebo, and the red is, and this was published in a British journal. That's why it's called hydroxycarbamide, but it is the same drug. It's just a different name, hydroxyurea. So you can see this is the acute chest syndrome that I was showing you before, that this is the number of weeks. You can see there's much less of it in the hydroxyurea compared to the placebo. Similarly, there's less pain over time, less need for blood transfusions, and much less of the painful hands and swelling of the hands and feet. So this drug works. We know that it works. And this was a more recent study, 2013, from Brazil, where they looked at almost 2,000 children with sickle cell disease, and about a quarter or less than a quarter were on the hydroxyurea for various reasons. And they noted the ones on hydroxyurea, much less deaths. So there's 1% of them died versus 5%, and the ones who were not on hydroxyurea. There was less infections, less chest crisis, less hospitalizations, less emerge visits, and their hemoglobins were higher. So that was kind of a proof in principle of a large group that the hydroxyurea actually can save lives. So not only is there less complications, but you have less children dying. The next step up that criteria is a thing called a red blood cell exchange. And so this is what the machine looks like that you do red blood cell exchanges. And it's similar to a dialysis machine for those who may be familiar with that. But the way it works is you're trying to replace the sickle blood with non-sickle blood. And the point is that you're putting blood into sickle blood from the patient, goes into the machine, and then non-sickle blood is added in, and it goes back to the patient. So you're basically diluting out the so you're removing the sickled cells and you're bringing in red blood cells that don't have sickle. That's how it works. And you're aiming for a sickle cell hemoglobin to be less than 30%. You say, well, why is that? Why did they pick that number? Because we know, for those of you who are carriers of sickle cell disease, your blood is roughly 33% on average sickle blood. So we know that carriers really don't have problems other than extreme situations. They're very healthy people. So by doing this and bringing the S down to the same level as a patient who's a carrier, we know that you won't progress in the damage from sickle cell disease. This is a study actually of 200 children who had what's called a silent stroke. I was telling you that, where you do a scan of their brain and you see that there's a problem with the blood supply to an area of their brain, but there's no obvious signs. They're not weak on one side of the weakness of the face, not weak in their hands. And they did this study comparing transfusion to non-transfusion. So the observation group, so basically you can see it was roughly 100 in each side, 100 on the observation group. 7 children had a new stroke if they were just observed and done usual care. Whereas the ones who are being transfused, only 1 had a stroke. So it's not perfect, but it dramatically decreased the risk of stroke. And more importantly, I wanted to show you that this also looked at pain crises. So here we go, pain crises. You can see that even though the number of participants was roughly the same, that, you know, basically almost a third, as you had a third as many, only a third of the number of pain crises in the transfusion group versus the observation group, dramatic decrease in chest syndrome. You can see only 1 patient had painful erections in the transfusion group versus 10 in the observation group. And this problem with the bones, the hip problem, only 1 in the transfusion group versus 6 in the observation group. So it works, it decreases the complications. There is a trade-off, however, in that you have blood transfusion reactions. So there was obviously more blood transfusion reactions in the treatment group versus the observation group. You can see even though they weren't, they were observed, some of them did still need blood transfusion. And then this thing is ferritin is iron overload. You do see more problems with iron overload in the transfusion group. So there is a trade-off, but this is manageable. We can manage these problems with transfusion reactions, and we can manage the iron overload. We have a treatment for iron overload. So much better to prevent these bad things from happening, and then working around some of the issues related to transfusion. So then going further up the tree, is there's a thing called bone marrow transplant. And so I think many patients are aware of bone marrow transplant. And we often have, especially patients who newly come into Canada from other countries, the first thing they want is a bone marrow transplant because they say that's the thing to do. And there's definitely a role for bone marrow transplant in the treatment of sickle cell disease, but it is at this point, is for sort of a limited subsection. So the way it works is you have a recipient. So this in this setting is the patient with sickle cell disease who needs a bone marrow transplant. You decided to go ahead with that. You have a healthy donor. The recipient, or the person who's going to receive the bone marrow, has to get basically they need to get rid of the cells they have. And the way you do that is by giving chemotherapy or anti-cancer medication. And you can give radiation. For the most part, we don't tend to use radiation in sickle cell disease bone marrow transplant, but it depends on the center you're at and what they do. But it's usually anti-cancer drugs to get rid of all the cells that you have. And then the healthy donor, a needle is put into their hip bone and to remove the healthy marrow cells. It's a very relatively simple thing. It doesn't involve sort of multiple pokes. And so you're a bit sore for a day or two afterwards, but you remake your bone marrow. So the donor is back to normal within a few days, and really it's very minimal impact on the donor. And then those cells are then given to the recipient. So that's how bone marrow transplant works. What are the results? So this is a publication from 2017, so it's about 5 years old. But I just want to focus on this, the B chart right now. Again, this is one where every little tick down indicates an outcome. And in this case, it's survival. So every time you see this little tick down here means, unfortunately, a patient died after their transplant. But you can see that the majority of patients, and focus on the red line because that's bone marrow, that over 90% of patients, and this is out to 10 years, you can see how it flattens out here. And really, there's no patients who die after 5 years. It's very uncommon. So you can see more than 9 out of 10 people can survive after transplant, after bone marrow transplant. With that, there's other ways of doing it. This is called peripheral blood, and these are cord blood. But bottom line is the vast majority of patients we use this bone marrow transplant. The flip side, the downside to think about is there's this thing called graft versus host disease. And what that means is, so if we go back to the previous one, you're taking these cells and you're sending them to the recipient. The recipient, once those cells settle in, there's a take, they engraft, it's called engrafting. They can look around and say, hey, this doesn't seem right. These cells around me are not what I'm expecting. And they can actually start attacking the cells, thinking that this is some sort of invading, like a virus infection or some sort of invading thing. And they basically attack the body. And that's this graft versus host disease. And they talk about here is chronic graft versus host disease, which is one of the worst outcomes of bone marrow transplant. You really don't want to see this. And you can see that in adults, that can be you can see up to 20% of people can get chronic graft versus host disease. In children, it is lower, roughly 12 to 15% can get this chronic graft versus host disease. So yes, it's good, but there's still another group who've potentially cured their sickle cell disease, but unfortunately end up with this other problem called chronic graft versus host disease. There's a group at the American Society of Hematology that is looking specifically at sickle cell disease and trying to answer the question, which is what everybody has this same question: who should go for a bone marrow transplant? And so there's a group working on this right now, and they're asking these specific questions, so that we don't have the answers yet, but they're working on this. Should individuals with sickle cell disease and a neurological problem, such as a stroke, undergo, and this MSD means matched sibling donor transplant. So one of the things, and here I'm just going to backtrack a little bit, is that when you're picking the donor, it's really important that you get the best donor possible. The best donor is to have a brother or sister who is a match. And you say, well, how common is that? Well, in the case of sickle cell disease, it's a 1 in 5 chance of having a person who's a match who also doesn't have sickle cell disease, because if you have a patient who's got sickle cell disease, their brother or sister could also have sickle cell disease. So you're not going to take bone marrow from somebody with sickle cell disease, obviously, but you want them not to have sickle cell disease and also to match up. So it's only 20% of siblings will match up. So that's one of the biggest problems with bone marrow transplant, is that each sibling, you have a 20% chance. So if you're in a family of, if you've got a huge family, your chances are higher, but still it's not 100%. And if you're an only child or your only sibling has sickle cell disease, you for sure don't have a match. So they're talking about the best kind of match is matched sibling transplant. And so they're talking about, and one of the things they're going to look at is, does it improve and I didn't talk about this, the risk of stroke, having another stroke, blood vessel issues, quality of life. This is what this is. And then they're going to talk about should patients with frequent pain have a bone marrow transplant, and they're going to look at these issues. And should patients had a chest crises, recurrent chest crises, should they have a transplant? And these are the things that are going to be looked at. And so these are all kind of the thing, but we don't have all the answers yet. But bone marrow transplant, and I already mentioned this a little bit, there is a trade-off. There is potential harms. Obviously, the biggest concern is death, and I'm just going to talk about this. So there's a definite difference between children having bone marrow transplants versus adults. So if you're less than 16, your overall survival is 95%, and I was showing you a bit on the other graph. So 19 times out of 20, you survive. So that's very good. I mean, obviously, every individual, it's one, or either you die or you survive, but at least your odds are in your favor. And then the event-free survival means that things have worked out really well is over 90%, so 93%. So in children under 16, you can see the odds are seem to be pretty good. Whereas once you get over 16, then you have more problems with surviving and having potential problems. Now, this data is older data, so hopefully that'll get better now that we're more aggressive in treating. So maybe that the older patients are in better shape, so they may be able to tolerate transplant better. Then this graft versus host disease I was talking about, and again, it's better, and if you're younger, you can see that it's 12%, 12.6%. And more importantly is this chronic graft versus host disease, about 15%. And then if you're over 16, then you have a chance of having about 1 in 4 can get this chronic graft versus host disease, which is a real problem. We talk about graft failure, basically that doesn't take, the bone marrow doesn't take, and that's a real problem. And it can happen up to 5%, 5 to 10% of patients. Infection is a significant problem, and that actually is the main contributor to death. Many patients die if they're going to die from infection. We talked about infertility being a problem, and then malignancy. The one thing is in this commentary or this thing, it seems the risk of malignancy seems to be low overall. There's definitely always a chance of cancer, but I think Dr. Kuo, if you attended his talk, mentioned that unfortunately, just having sickle cell disease alone increases your risk of having cancer, potentially leukemia. So it's not a huge amount, but it does increase your chance of getting specifically blood cancers. So bone marrow transplant can add to this, but it doesn't seem to add a lot. But it is a concern. So speaking of overall mortality in sickle cell disease, so then we got to think about, okay, well, those are all the risks of the various treatments. Okay, what are the risks of actual sickle cell disease? So this is the trend over time that way back, this is from back in 1979. You can see there was a lot of children dying of sickle cell disease. But the good news is this was published in 2006, is that many of those deaths were prevented, and that's by using preventative penicillin, and the vaccines are getting much better. So vaccines are crucial for preventing death in children in sickle cell disease. And then you can see that there's a shift in the curve. So the median here was in the 30s of dying from sickle cell disease, and here has moved into the 40s and almost 50s in 2006. And this is just kind of another way of showing it. You can see that the survival of sickle cell disease was very, very poor up until the 1970s. Things improved when we started using penicillin, we started using hydroxyurea and transfusions. And then this is the sort of hot off the presses, very recent data in 2022. You can see that going back to 2008, which is basically where this graph left off, was 2006. So you can see the median was close to 50% of the median survival age. And when you compare, this is US data, so they compared it so that you can see there was 6,000 patients with sickle cell disease compared to 5 million people without sickle cell disease. Similar, there was matching to do racial matching and age matching. And you can see that here there's a 25-year difference between this median survival in sickle cell disease and the average population. But over a very short period of time, you look at this, this is 15 years, you can see that the average lifespan increased to 60, and the median is up to 60. So that's quite dramatic that we're having this. So, you know, when I went back to 1979, it was in the 30s, then it's the 50s, and now median lifespan is the 60s. So dramatic improvement. And this particular thing was talking about L-glutamine and crizanlizumab and voxelotor, although Dr. Kuo was kind of pointing out, unfortunately, these drugs are not turning to be quite as useful as we'd hoped. But I personally think it's the widespread use of hydroxyurea. This is having the major improvement in this. And this is a kind of another way of looking at it, is even just going back 5 years, you can see that 40% of the people who were dying of sickle cell disease were over 60, but now 50% of them are over 60. So people are living longer with sickle cell disease. So I think this is quite a dramatic improvement. We're not where we want to be. We want to have it at parity with the sort of non-affected population, but it is dramatically improving. You can see this. This is only over a 5-year period. So major advances. So in conclusion, sickle cell disease can cause significant organ damage and shortened lifespan. I think I showed that in the pressing diagrams at the beginning, showing all the various areas that can be affected. But we can prevent organ damage by using hydroxyurea. And for those who hydroxyurea doesn't work, using transfusions, chronic transfusions. So we can prevent the problems. And then for especially those the small number who have a matched sibling, bone marrow transplant can be curative in eligible patients. And hopefully we're going to get more nuanced understanding of who's the best people to do that. But I think one of the things is we are looking more and more into patients with sickle cell disease, especially if they're having problems, to check out their siblings to see if they're a match. And then the last point is the median lifespan of patients with sickle cell disease is steadily approaching that of the healthy population, which is very good news. So I'm trying to end, I'm ending on, I think, is a very positive note. And at this point, I'd like to, I'm ready to take on some questions.
Thank you. What a great presentation. Thank you so much. And you did leave us with some time as well, about 12 minutes to take some questions. So I can open the floor up. You can either drop your questions in the Q&A or in the chat, or if you'd like to raise your hand, I can also allow you to speak and you can ask any questions. So I guess in the interim, I do have questions myself, Dr. Klassen. I guess my biggest question is, currently with the management of organ donation, damage, does it differ? Like, how is it right now within spaces in terms of medical and hospitals, in terms of being like interdisciplinary or multidisciplinary? Is that something that is a concern in terms of getting, a lot more doctors, I guess, are going to be on your team with your hematologist, your physician? What is that process like currently? Is that something that requires a lot more advocacy and awareness and education in terms of the healthcare system?
No, that's an excellent point. And I'm gonna do a little preface in this. I'm a pediatrician and my job is to make sure I try to avoid all organ damage while they're a child, which we don't do that 100%. So we certainly do have some patients, for instance, who, get that necrosis of the bone, and we have to interact with the orthopedic surgeons. We have a bone specialist at our institution. We interact with that bone specialist, and if they have lung problems, interacting with the respirologist. So we do some of that. Fortunately, even though we follow a number of patients at our hospital, the complications are relatively low. So that's good news for the patients, but the bad news is that people don't get a lot of experience. So the respirologists don't deal with a lot of patients with sickle cell disease. Similarly, the bone specialists and so that's always an issue about education. The nice thing I have, we're a relatively small community within CHEO, and I know the players. I've been at it for so long. I know everybody well, so we can. And I should point out this: Dr. Simpson actually does most of the work. I give the presentation, but she actually does all the work. And so we have a very good relationship with our teams, and we have conversations about, especially, for instance, we sending our patients to the emergency department. We make sure the emergency doctors are aware that they're coming. We have an ongoing conversation to make sure they know what our plan is, and they defer to us. They're very good about reaching out to us. If our patient's going for surgery, we talk to the anesthetist. There's a lot of conversations going on. And I got to admit, it's a little bit easier for me because, fortunately, we don't have as many patients with problems, so it's less conversations. I know it's a more challenging situation on the adult side because their volume is much bigger and there's a lot more complications. So it is really challenging. And unfortunately, I can't give you a clear answer on how it works on the adult side. I know they're working very hard to improve the communication. And I mean, the plenary session, you know, the Dr. Soul sort of did a really nice job of explaining how he interacts with his various specialties to get them involved. Yeah, it's a really important point.
Yeah, thank you. I'm glad that that's happening at CHEO. I'm hoping it is also happening across Canada as well with patients. But I do have a question from the chat. So the attendee said, for young people with early intervention, does that impact the potential for repair as they grow into adolescent and adulthood?
Yes, so that's so important is once the damage is done, you can do some repair, but the damage is already there. So your best way around this is to prevent the problems. And that's where hydroxyurea really comes in, is really crucial. And the way it works, I kind of mentioned that it increases that fetal hemoglobin. And that data comes from, there's some types of sickle cell disease where they are born with high fetal hemoglobins and they tend to have much less complications. So that's where a lot of that kind of, and we know that patients who have higher fetal hemoglobins have less sickle complications. So yes, by having them on hydroxyurea, pushing up that fetal hemoglobin as high as you can get it. I have some patients who can get up to 40%, you know, some in 30%, and ideal at least over 20%. We can prevent some, if not all of these. Can't prevent all the complications, but we could greatly decrease the risk of getting those complications. And actually, it makes it a little bit challenging because many of our patients do quite well, and so then when you then look at the risks of transplant, you could say, well, gee, is it worth taking the risk? Because we can't predict who's going to get into real trouble later on. Because that's what we would like to know is, okay, I have 100 children. These 10 or these 20 are going to really get into trouble 10 years from now, 20 years from now. So it's worth taking the risk of going through a bone marrow transplant because we know. But the problem is we can't necessarily predict that. The patients who are already having problems, you can say, okay, well, if they're having problems now, probably that's going to continue. But, you know, occasionally you have some who have problems, goes away, others who don't have problems, and then all of a sudden start having trouble. So it's not 100%. It's not 100%, but that's a great question. Thanks.
Yeah, thank you. And the other question that's in the Q&A box is, you mentioned that hydroxyurea is an old drug. Is there sufficient funding to facilitate more research to develop more drugs to manage sickle cell disease?
Right. And for those of you who didn't get a chance to see Dr. Kuo's presentation, it was really phenomenal because he went through all the details of all the various treatments that are out there. It's actually kind of overwhelming about all so there's lots of work happening. There's no slam dunk, and there are, and we mentioned there's 3 drugs that were approved by the FDA in United States. But unfortunately, the results, so initially there was a lot of excitement about those, but then they kind of cooled off, and then unfortunately, they're not turning to be as effective as we'd hoped they would. So these approved drugs, but unfortunately they aren't, you know, living up to, for most patients, living up to what their standard is. So that we do definitely need new drugs, and there's lots of studies going on, and there's studies going on within Canada. So definitely you can talk to your clinician and say, you know, I'm interested in looking into studies and see if there is a study that's open for yourself or your child. Not so much in pediatrics at this point, but I think it's pretty close because I think some of those drugs will they'll open up studies in children, and you know, so you can ask your clinician if there's a study that you can look into, because that's how these new drugs get on the market, is they have to do the studies. So if you really want to have a new drug for sickle cell disease, fortunately or unfortunately, you've got to step up to the plate and offer either yourself, or if you're a parent, volunteer your child to participate in these studies, because that's how new drugs get approved. you know, because you wanted it done, due diligence done before we widespread use a drug. We need to make sure it's safe and effective.
Absolutely. Thank you. And there's a last question here. Mrs. Are bone marrow transplants accessible? Are they in high demand for other bloodborne disorders? So definitely looking at the equity component of bone marrow transplants.
Certainly you can get definitely can get bone marrow transplants. For instance, we don't do it in pediatrics. We don't do it at our center. It's done at the Hospital of Sick Children or in Montreal. But in the adult side, most places do, most of the major centers do bone marrow transplants. I think it's a good question around sort of equity and access. There can be delays, and it can take seem like a long time to get the bone marrow transplant. But if you're eligible and in discussion between your clinician and the bone marrow transplant team, they think you're a good candidate for bone marrow transplant, it should happen. It doesn't happen as fast as you would like, you and I would like, because I got to admit, there is a bit of there is some priority to cancer patients, mainly because they don't have the luxury of waiting. So to be fair to them, they have a time. There's a time component with them, whereas with sickle cell disease in general, you have some luxury of time. But again, you do need to press to get these transplants to happen. But I think it's definitely better now than it was, say, 10 years ago. I think it's certainly awareness that bone marrow transplants should, in hemoglobinopathies, sickle cell and thalassemia, should be happening. Yes.
Great. Thank you so much, Dr. Klassen, for that very educational and informative presentation and for answering all the questions. This is the end towards the end of the session, but before everyone goes, there will be a poll that will be posted and launched. I believe if it's not already launched, if you can just take a moment to please just provide your feedback, that would be greatly appreciated moving forward. But thank you so much again, Dr. Klassen, for your amazing wealth of knowledge. And thank you everyone for also attending and participating as well with your amazing questions as well. So thank you and enjoy the rest of the summit. Take care.
It was my pleasure. Thank you so much.